This lecture will cover Chapter 40 in your Lewis textbook, Obesity. Obesity is an excessively high amount of body fat or adipose tissue. It's a major health problem because it increases the risk of many other diseases such as diabetes and cancer. Whether obesity should be labeled as a disease is still a controversial topic. In 2008, the Obesity Society announced their support for calling obesity a disease. Attitudes about obesity can create biases and discrimination against people who are overweight or obese. It needs to be viewed and treated as a chronic disease similar to other chronic illnesses such as diabetes and hypertension. It's a major health problem for adults and children. An important part of your patient assessment is to determine and classify a patient's body weight. Is it primarily obesity or secondary obesity? The majority of obese people have primary obesity, which stems from the excess caloric intake from a body's metabolic demands. Secondary obesity could be from a chromosomal or congenital anomaly, a metabolic problem, central nervous system lesions or disorders, and drugs such as steroids, antipsychotics. The degree to which a person is classified as underweight, normal weight, obese, or extremely obese can be assessed using several methods. A number of assessment methods are available, including BMI, waist circumference, waist-to-hip ratio, and body shape. The most widely used and endorsed measures are BMI and waist circumference. These measures are cost-effective, reliable, and easily used in all practice settings. The most common measure of obesity is the BMI. BMI is calculated by dividing a person's weight in kilograms by the square of the height in meters. Tables make calculating BMI unnecessary. The BMI, which provides an overall assessment of fat mass, must be considered in relation to the patient's age, gender, and body build. For example, a bodybuilder may have a BMI associated with obesity, but because of high muscle mass, the BMI would not be an accurate assessment. In contrast, in individuals who have lost body mass, the BMI would underestimate the degree of obesity. For this reason, other measures must be combined with the BMI for an accurate evaluation of a person's weight. Individuals with a BMI less than 18.5 are considered underweight, whereas those with a BMI between 18.5 and 24.9 reflect a normal body weight. A BMI between 25 to 29.9 are classified as being overweight, and those with values at 30 or above are considered obese. The term obesity is used for those with a BMI greater than 40. Waist circumference is another way to assess and classify a person's weight. The average waist size has increased by more than 1 inch in the past decade. Health risks increase if the waist circumference is greater than 40 inches in a man and greater than 35 inches in a woman. People who have visceral fat with truncal obesity are at increased risk for cardiovascular disease and metabolic syndrome. The waist-to-hip ratio is another method used to assess obesity. This ratio is a method of describing the distribution of both sub-Q and visceral adipose tissue. The ratio is calculated by using the waist measurement divided by the hip measurement. A waist-hip ratio less than 0.8 is optimal. Anything greater than 0.8 is going to indicate truncal fat, which puts the patient at risk for greater complications. Body shape is another method of identifying those who are at risk for health problems. Individuals with fat located primarily in the abdomen area or apple-shaped have android obesity. Those with fat distribution in the upper legs, a pear-shaped, have gynoid obesity. Genetics has an important role in determining a person's body shape and weight. The magnitude of the obesity problem is a public health crisis. African Americans and Hispanics have higher rates of obesity. Currently, about 34% of adults in the U.S. are obese. Significant geographic, racial, and ethnic and income disparities exist. Obesity in adulthood is often a problem that begins as early as childhood or adolescence. Reversing the childhood obesity crisis is key to addressing the overall obesity epidemic. Obesity is an increase in body weight beyond the person's physical requirements. This results in an abnormal increase in accumulation of fat cells. However, the process leading to and sustaining the obese state are complex and still undergoing investigation. Adipocyte hypertrophy is a process by which adipocytes can increase their volume several thousandfold to accommodate large increases in lipid storage. When pre-adipocytes are triggered to become adipocytes, it primarily occurs in the visceral or intra-abdominal and subcutaneous tissues. The process of hyperplasia, or increase in the number of cells, of adipocytes is greatest from infancy through adolescence. Studies of twins suggest the existence of genetic factors in obesity. However, genetic factors do not totally account for the etiology of obesity. Estimates of obesity as an inherited problem are more than 50%. A number of genes have been identified as being linked to obesity. Genes actually may be influenced how calories are stored and how energy is released. Energy-thrifty genes, once protective against long periods where food was not available, are now maladaptive in societies where food availability is no longer a primary issue. Genes may be responsible for why two individuals living in the same environment can vary considerably in body size, but more research is needed. Knowing how appetite is triggered and energy is expended provides important information for understanding obesity, as well as specific targets for the development of drugs. The hypothalamus, gut, and adipose tissue synthesize hormones and peptides that stimulate or inhibit appetite. The hypothalamus is a major site for regulating appetite. Neuropeptide Y, produced in the hypothalamus, is a powerful appetite stimulant. When it is imbalanced, it leads to overeating and obesity. Hormones and peptides produced in the gut and adipose site affect the hypothalamus and have a critical role in appetite and energy balance. Leptin is secreted from adipocytes when they fill with fat. A genetic deficiency of leptin causes extreme obesity. In obesity, the level of leptin is actually increased, which has raised the question of whether obese people are insensitive to leptin. Possibly causes of obesity include failure to produce enough leptin receptors or production of receptors that are faulty. Ghrelin is a gut hormone. In a fasting state, ghrelin is increased. Ghrelin acts in the hypothalamus by working on the reward system that triggers overeating. Ghrelin is thought to play a part in compulsive eating. In gastric bypass surgery, ghrelin is decreased significantly, which helps to suppress appetite. Adipocytes produce at least 100 different proteins. These proteins, secreted as enzymes, adipokines, growth hormones, and growth factors and hormones, contribute to the development of insulin resistance and atherosclerosis. An increased release of cytokines from the fat cells may disrupt immune factors, thus predisposing to certain cancers. Because visceral fat accumulation is associated with more alterations of these adipokines, people with abdominal obesity have more complications of obesity. Environmental factors play an important role in the development of obesity. In today's culture, there is a greater access to food, particularly foods that have poor nutritional quality, prepackaged and fast foods, and soft drinks. Eating outside of the home interferes with the ability to control the quality and quantity of food. Portion size have increased dramatically. Underestimating portion sizes and therefore caloric intake is common. With increases in technology and labor-saving devices, Americans are expending less energy in their everyday lives. Elimination of physical education programs in schools, along with increased time playing video games and watching TV, have contributed to an increase in sedentary habits. Socioeconomic status is a known risk factor for obesity in a variety of ways. People use food for many reasons besides their nutritional value. Association with food begins in childhood, such as the use of food for comfort or rewards. When overeating develops at an early age and continues into adulthood, one's ability to sense fullness is altered. Whether triggered by specific foods or when there is simply a wide variety to choose from, some people consume more food than their body needs. The lack of hunger that drives eating has been termed mindless eating, and it leads to a consumption of unnecessary calories and increase in body weight. The social component of eating begins early in life when food is associated with pleasure and fun at such events as birthday parties. All of these factors must be included when considering the etiology and treatment of obesity. Hippocrates wrote that corpulence is not only a disease itself, but the harbinger of others. Thus, recognizing that obesity has major adverse effects on health, many problems occur in obese people at higher rates than people of normal weight. It can increase their mortality rates as obesity increases, especially when obesity is associated with visceral or abdominal fat. In addition to these problems, obese patients have a reduced quality of life. Fortunately, most of these conditions can improve if an individual loses weight. Obesity is a significant risk factor for cardiovascular disease and hypertension in both women and men. As many as 80% of people with type 2 diabetes are obese. Obesity can lead to a number of medical problems, including osteoarthritis, sleep apnea, gastroesophageal reflux disease, gallstones, non-alcoholic steatohepatitis, or NASH, and cancer. Obesity in older adults can exacerbate age-related declines in physical function and lead to frailty and disability. Obesity is associated with hypertension, which can occur because of the increased circulating blood volume, abnormal vasoconstriction, and increased inflammation and increased risk of sleep apnea. Altered lipid metabolism and hypertension can increase the long-term risk of heart disease and stroke. Excess body fat can also lead to chronic inflammation through the body, especially in blood vessels, thus increasing the risk of heart disease. Obesity is a major risk factor for the development of type 2 diabetes. Hyperinsulinemia, or insulin resistance, which are common features of type 2 diabetes, are found in obesity. The term diabesity reflects the combined effects of diabetes and obesity. Excess weight decreases the effectiveness of insulin. When insulin does not work effectively, too much glucose stays in the bloodstream. Thus, more insulin is made to compensate. Pancreatic B cells get overworked and become worn out. Over time, the pancreas is no longer able to keep blood glucose in normal range. Adiponectin, a peptide that increases insulin sensitivity, is decreased in obese people. Obesity complicates the management of type 2 diabetes by increasing insulin resistance and glucose tolerance. These factors make drug treatment for diabetes less effective. GERD, or gastroesophageal reflux disease, and gallstones are more prevalent in obese people. It's typically due to the supersaturation of the bile from cholesterol. NASH, or non-alcoholic steatohepatitis, is a condition in which lipids are deposited in the liver, resulting in a fatty liver. NASH is associated with elevated hepatic glucose production. It can eventually progress to cirrhosis and become fatal. Increased fat mass is associated with breathing problems that can substantially improve with weight loss. Breathing problems at night may cause poor sleep, sleep deprivation, and result in an increase in appetite. Building up a sleep debt over a matter of days can impair metabolism and disrupt hormone levels. The level of leptin falls in people who are sleep deprived, thus promoting appetite. Obesity is associated with an increased incidence of osteoarthritis because of the stress put on weight-bearing joints, especially the knees and hips. Increased body fat also triggers inflammatory mediators and contributes to the deterioration of cartilage. Hyperuricemia, or increased levels of uric acid, and gout are often found in people who are obese and in those who have metabolic syndrome. The underlying mechanisms between obesity and cancer remain unclear. Breast and endometrial cancer may be due to the increased estrogen levels associated with obesity in postmenopausal women. Colorectal cancer has been linked to increased levels of insulin. Esophageal cancer may be secondary to acid reflux caused by abdominal obesity, and hormones may potentiate the risk for cancer. Insulin, a powerful cellular growth factor, is increased in obesity and may affect cancer cells. Adipokines from fat cells may stimulate or inhibit growth cells. For example, leptin, which is increased in obese people, promotes cell proliferation. The consequences of obesity extend beyond the physical changes. Stigma of obese people, and in some cases discrimination, occurs in three important areas of living: employment, education, and healthcare. The social stigma associated with obesity has an emotional toll on a person's psychological well-being. Many obese people suffer low self-esteem, withdraw from social interaction, and experience major depression. A thorough history and physical exam are the first approach to treating obesity. We need to explore genetic and endocrine factors such as hypothyroidism, A thorough history and physical exam are the first approach to treating obesity. We need to explore genetic and endocrine factors such as hypothyroidism, hypothalamic tumors, Cushing's syndrome, hypogonadism in men, and polycystic ovary syndrome in women. Laboratory tests assist in evaluating the cause and effect of obesity. When no organic cause is associated with obesity, the disorder should be considered a chronic, complex problem. Patients may withhold information out of embarrassment or shyness. Information that can assist the student in understanding an obese patient and provide a basis for intervention is presented in Table 40.6 of your textbook. Examine each body system with particular attention to the organ system in which the patient has expressed a problem or concern. Have the right equipment to take measurements. Provide special chairs, examination tables, and scales that can accommodate an obese person. Assess for any comorbid diseases associated with obesity, such as hypertension and sleep apnea, as some of these conditions will require special treatment. We need to first assess a patient's willingness to change and potential for change. If people are not ready for change, offer them the opportunity to return for further discussion when they are ready to discuss their weight gain and make lifestyle changes. You have a major role in planning for and managing the care of an obese patient with other members of the interprofessional care team. Pay attention to your own beliefs and biases. Your attitude will be conveyed to your patient. Help obese people explore and deal with their negative experiences. Teach other health professionals about stigma and biases experienced by obese patients or people. Healthcare providers are often reluctant to counsel patients about obesity for a variety of reasons. These include the following: time constraints. Weight management may be viewed as professionally unrewarding. Reimbursement for weight management services is difficult to obtain, and many healthcare providers do not feel knowledgeable about giving weight loss advice. Despite the known benefits of weight loss, it is a difficult process for most individuals. In general, the average weight loss program, except for bariatric surgery, results in a 10% reduction of body weight. This average reduction should not be considered a failure since it is associated with significant health benefits. Focus on the reasons for wanting to lose weight to help patients develop strategies for weight loss. A multi-component approach for weight loss needs to be used that includes nutritional therapy, exercise, behavior modification, and for some, drugs or surgery. Focus on more than one aspect provides for more effective weight loss and weight control efforts. While doing patient teaching, stress healthy eating habits and adequate physical activity as lifestyle patterns to develop and maintain. No one diet is superior for weight loss. A supervised diet plan may be prescribed that limits calories to a total of 800 or less per day, but this is not sustainable on a long-term basis. These diets should only be provided by trained professionals in a medical care setting. People on low-calorie and very, very low-calorie diets need frequent professional monitoring because the severe energy restriction places them at risk for multiple health complications. In general, it is best to recommend a diet that includes adequate amounts of fruits and vegetables, provides enough bulk to prevent constipation, and meets daily vitamin A and vitamin C requirements. Lean meat, fish, and eggs provide sufficient protein and the B-complex vitamins. It is rare to find an obese person who has not at some time attempted to lose weight. Fad diets tend to restrict one category of foods, therefore these should not be encouraged. These restricted diets are difficult to maintain on a long-term basis. The more restrictive the regimen, the greater the demand for intense discipline in the face of an intense desire to eat foods not allowed on the diet. The ability to adhere to a diet and degree of weight loss strongly depends on the patient's motivation. A moderately obese person will obviously obtain his or her goal more easily than a person with extreme obesity. The obese patient must recognize the advantages of weight loss and weight control. You can assist by helping the patient track eating patterns with a diet diary. Setting a realistic and healthy goal, such as losing 1 to 2 pounds a week, should be mutually agreed on at the beginning of a weight loss program. Trying to lose too much too fast usually results in a sense of frustration and failure for the patient. You can help patients understand that losing large amounts of weight in a shorter period of time causes skin and underlying tissue to lose elasticity and tone. Slower weight loss offers better cosmetic results. Remind the patient that plateaus are normal occurrences during weight reduction. A weekly check of body weight is a good method of monitoring progress. Daily weighing is not recommended. There is no clear consensus on the number of meals to be eaten when a person is on a diet. Because men have higher percentage of lean body mass, they are often able to lose weight more quickly than a woman. Women have a higher percentage of body fat, which is metabolically less active than muscle tissue. Postmenopausal women are particularly prone to weight gain, especially increased abdominal fat. Food portion sizes need to be relearned. Foods can be weighed on everyday objects can be used as guides. For example, the size of a woman's fist or a baseball is a serving size of a vegetable or fruit. A person's palm or a deck of cards can be a serving size for a piece of meat, and a thumb or 6 dice is a serving for a piece of cheese. Another aspect of the American diet that needs to be considered is which foods contribute the most to calories. Animal sources, fruits, grains, or vegetables. 2/3 or more of an individual's diet should be plant source foods, and the other 1/3 or less should be from animal protein. A list of healthy or low-calorie foods serve as a good reference. Encourage the appropriate fluid intake in the form of water. Alcoholic and sugary beverages should be limited or avoided since they increase caloric intake and are low in nutritional value.